All right, why don't we get started? Again, I want to introduce myself. My name is Cameron Sholty. I'm the Director of Government Relations at the Heartland Institute. Also joining me today is Christina Herrin, State Government Relations at the Heartland Institute for Healthcare Policy. We're doing a webinar on healthcare policy in the states, a legislative wrap-up looking at some of the innovations and policies pursued in the states by state legislators. Like today's participants, what was going on this past session. It's an informal conversation, but generally I'm going to hand the program off to Christina. She's going to go over and review the legislative session, and then I will ask her some questions to kind of keep the conversation flowing. If anybody has questions for her, we'll take those probably in about a half hour or so. And if you do have a question, just raise your hand or throw it into the Q&A section. And Jim Lakely, our VP at Heartland Institute, will catch those and flag those to be answered. So without any further ado, I want to welcome Christina and pass the show off to her.
Yeah, well, thanks for having me, Cameron. And Heartland has been really active this session, both federally and on the state level. Like Cameron mentioned today, we're going to touch on really the state wins that we've had and legislation we've seen movement on within the states. And obviously, COVID-19 was a huge hot topic this legislative session in terms of actual policy regulations that were rolled back, temporarily suspended, and then some states actually went to permanently codify those rollbacks, and that was awesome to see. And then we've also seen a lot of politicians that are oftentimes reactionary, right? As free market thinkers, we often have to react to bad policy, but there's actually some really good policy introduced this legislative session, so I'd be happy to talk about that. So one of the big topics was telemedicine expansion. And obviously during COVID-19, people were very fearful to go to the doctor or didn't want to go with fear of contracting the virus. And so a lot of states did end up permanently expanding telehealth access. And we saw that in Connecticut just recently. Montana permanently expanded their telehealth services and rolled back regulations. And, that's especially good for rural residents in Montana. Arizona a while ago expanded telehealth, and that's just really nice to see. And other states have expanded the policy as well, but those are the states that we are really active in. And then also in regard to the COVID-19 pandemic, 24 states temporarily suspended con law during the height of the crisis, and several states then went to permanently reform their certificate of need law. So that was awesome. Tennessee reformed con. They rolled back policies for mental health facilities. They also reduced the annual fees for nursing homes and surgical centers and home care organizations. And then it also shortened the length of its certificate of need approval process, which anyone out there who works on certificate of need reform knows that those approval processes can be so lengthy and very costly. So that was awesome to see in Tennessee. Alabama attempted con reform, and Alaska did as well. And we testified in Alaska several times on the bill, and unfortunately it just didn't get past this go around. And I know Alaska, there have been supporters of certificate of need law in Alaska for many years. And so hopefully, in the future, that's something that they can finally accomplish and pass. North Carolina also attempted a certificate of need law repeal, and we were active there. And then, Montana did also reform con, which was great. And that was a great first step. And, if reform could be your first step and then repeal be our, final step down the line, that would be awesome to see as well. And then going back to some other healthcare issues, we had some fights in the tobacco harm reduction arena. Here in Illinois, that's where the Heartland Institute is located. There was a flavor ban instituted here in the state of Illinois, and there's already a flavor ban on, e-cigarettes, but Illinois decided to try and institute an e-cigarette ban as well. And we've been fighting tobacco and vaping excise taxes and regulations for years now as well. And then just a couple other things. We saw a lot happen with direct primary care this year, which is kind of a newer topic. It's an alternative to our third-party health insurance that most, people use, and this is a great alternative. It lowers costs and gives patients, access to doctors that they might not normally have access to. So, it's a great proposal, and South Dakota and West Virginia did pass legislation that would define direct primary care as differently than your regular insurance, so they can kind of avoid some of those administrative costs and fees that are, part of the reason healthcare is so expensive. Iowa and Missouri and Texas actually have a really interesting pieces of legislation as well. They all three had direct primary care pilot program legislation for Medicaid. So this would allow direct primary care to be expanded to Medicaid patients, and the cost savings in this type of program could be huge. And so this is just something that the Heartland Institute, and I know a lot of people in the healthcare field and healthcare, policy field are kind of looking into, and I think it's going to be something that's going to be more popular. So direct primary care, if you're not, looking at that as an option for your state, I definitely think that's going to be something on the horizon. South Carolina also introduced direct primary care agreements, and then Mississippi has had a primary care shortage. And they're dealing with some licensing issues, which could also similarly be tied into this. And then we also saw, again, with some of this proactive legislation, we saw the state of Iowa, my home state, ban mask mandates. So not allowing local governments to create, really overreaching policy that would require businesses to mandate masks. And then we saw something similar in Michigan happen as well, where they passed legislation, preemptively expecting that there would be vaccine passport card requirements. So not allowing that type of invasive policy to occur. And I think that's a really awesome thing that we're starting to see from this pandemic, is that legislators that are fighting for individual liberties and these civil liberties are being proactive instead of this reactionary where we're always having to battle legislation that's already been introduced and we're stopping it, ahead of time. So I think that was really great to see. And then just two more things and I'll get off my soapbox, but we've seen Medicaid expansion. This has been pushed for a while now, and we saw it in the last COVID-19 stimulus package. Wisconsin actually just killed Medicaid expansion in their state. And I know a lot of states did take, Medicaid handouts. And again, I understand that can boost your state's budget, but at the end of the day, it's going to be on the taxpayer. For example, the COVID-19 recent stimulus package, it only guaranteed payment for these Medicaid plans for 2 years. So after 2 years, that falls back onto the state and back onto the taxpayers. So it was really great to see Wisconsin kill Medicaid expansion. And then I think lastly, I guess that's all I have, other than we had some alcohol sales stuff going on in Texas. If you're a Texan out there, there's a lot of regulations within the distilleries and selling alcohol on Sundays. So some people refer to it as blue laws or Sunday sales. And there were 3 bills and they did die, all 3 of them. But hopefully in 2 years when Texas is back, hopefully we can get more grassroots support on that type of legislation. So that's about all I have. Some sessions obviously have not ended yet, and so we still have some legislation that we're waiting on. But we did see some good things come out of the COVID-19 pandemic with the telemedicine and direct primary care and con reform. So that was awesome to see.
Thanks, Christina. That was great. I know you've been very busy monitoring healthcare policy in all the states. You testified and you submitted testimony. You testified in virtually in some cases, I know. And the healthcare policies that state legislators pursued were wide-ranging, and some states were more active than others. Did you see which states were the most active and which states could have and should have done more, in your opinion, in opening up their healthcare markets with the intent to drive down costs, and certainly, obviously, to be more responsive to pandemic?
Yeah, well, I mean, obviously, I think our red states were the most active and responsive. And I don't have a list out in front of me of, I know there have been state rankings of what states stayed the most open and the economic impacts of all of that. But I think definitely, I don't know if it's because we're in the heartland and we notice that, more than we do maybe on the coasts. But I think definitely Montana, South Dakota, Iowa, had really good initial policies, and then definitely followed through with some of their reforms that they temporarily suspended. And I definitely also think that there are 24 states that temporarily suspended certificate of need laws during the pandemic. 24 states did not permanently reform that legislation. So that kind of begs the question to me, if these laws are not necessary during the times of, the most critical healthcare crisis in our country's history, why are they necessary now and in the future? And I think that those states missed the mark. And I'm sure there were legislators that were, pushing it in their states, and some of their states have, more of a split legislature. But I do think that if you temporarily suspended or rolled back any regulations for telehealth and things of that nature, that should obviously be permanently codified, because again, it begs that question, if this was not necessary during the height of the COVID-19 pandemic, there is absolutely no logical argument that it would be necessary any other time. And as we know, the free market can respond better than government can ever try to. So I really would have liked to see more states that did those temporary suspensions permanently suspend.
I think that's a really great point you raise, is in that it's you work in government relations, I work in government relations. And so sometimes we have to keep an eye towards what is politically possible, right? And there's always pushback. It's one thing to sit at a distance and to talk about what a good policy is, what a bad policy is, and to swing for the fences on policy. But with state legislators, they're in this oftentimes and certainly during pandemic, in this unenviable position of weighing a pandemic and public health and economic distressors in their state. And so to your point then, is that these legislators are trying to find ways to both increase access to healthcare and to drive and simultaneously drive down costs. And so take, for example, a certificate of need law, then repealing that or suspending a con law in response to the pandemic, obviously, and this is exactly the point you made, is why was it needed in the first place? If it is the right policy during a pandemic, then it ought to be the right policy at all other times, right? Because then otherwise you're creating this bureaucracy, this bureaucratic morass of red tape, which inhibits innovation. So I guess the question then on that is, if you were talking to legislators, like you get to today, as a matter of fact, if they had to pick, say, 3 policies that were easy politically to do, or 3 reforms or policies, what are those 3 that might be easy or bipartisan, regardless of whether your state is a blue state or a red state?
Well, my first one, my advice would be telehealth expansion. I think it's a very easy sell. I think it's completely nonpartisan policy. Allowing patients to have access to medical care is good for everyone. And obviously, there are occasions where if you're getting a heart transplant or have to go to physical therapy, those might be good examples of when telehealth would not be a good option. But I'm from Iowa, and we have very rural communities that are several hours away from a healthcare specialist. And so allowing those patients, especially like during the COVID-19 pandemic, when there was a huge drop in, in folks going to the hospital or going to the doctor, there's a huge drop in care. And so allowing those people to have access with utilizing technology is a no-brainer. I mean, we have technological advancements that are outpacing the healthcare market, and we need to allow patients and doctors to use those resources. So to me, that is a simple no-brainer. I think that would be best for everyone. I think certificate of need law is a little more tricky just because of the cronyism involved. I think that you have more outsiders to battle. Obviously, established industry leaders oftentimes are not supportive of certificate of need law reform. It's really great for these big industry leaders to have to force have the power or have to force arbitrary regulations on smaller facilities or not let them into the market at all. And that's great for their pocketbook, but not for the consumer. So I would just take a free market approach to con law. I think that would be one of the most beneficial policies to pass. I think it is a little more difficult, but I think, the nature of the free market works, and to just be able to articulate that to your constituents and, remind them that the goal is for them to have the best care accessible at the lowest cost, and forcing facilities or new healthcare startups to have to go through government regulations and then allow industry leaders who are already established to have a say oftentimes in that process is a huge problem and just breeds cronyism. So being able to battle that, I think, would be tricky sometimes, but I would say do your best. I think that'd be the most beneficial though. And then I guess my third, easier policy. I don't know if anything's easy, but I would say refusing Medicaid expansion. Medicaid expansion, again, especially, a great example is the most recent COVID-19 stimulus package that the Biden administration has pushed out and shoved down our throats. It's 2 years. For 2 years, that'll be paid for by the federal taxpayer, or the federal tax dollars are going to be pushed to you. But then after that, that's on your state, and that's on your taxpayers within your state to handle. And I think a good example is what Wisconsin did. They have a very, very small gap in coverage. Most people are covered under the Obamacare exchange or the private market, but the recent push for Medicaid expansion would have put 91,000 people who are on the private insurance market onto Badger Care Plus. And that's completely not necessary. And it is just it's just a stepping stone towards socialized medicine or universal health care, whatever they call it these days. And I think being able to say no to that, and being able, again, to articulate to your constituents why this is a bad financial decision. And I think use basic budgeting skills. My fiance and I have a budget. And so I think explain to them that this runs out in 2 years. We really need people to pay for their own healthcare because we can't afford it as a state, and use those tax dollars elsewhere, or cut spending and then cut taxes would be a great alternative to, taking Medicaid handouts from the federal government. So I would say, being able to say no to that is a really, really strong, even if it's attached to other policies. And I think that every state is going through that, where they attach Medicaid to other policies. And I think that's also very wrong. I think bills should be voted on individually, but I think being able to vote no is the easiest thing you can do there on that.
So following up on that, I have a few more questions that I think will be helpful as state legislators think about this past session and what's coming in the next session. And as they start to think about what their agendas, what a healthcare agenda might look like in their state, as they start thinking about this in the fall and going into winter. And I know we haven't even made the first day of summer yet, but this is about when legislators start thinking about these things. So thinking about MA expansion, we'll take them in reverse order. Thinking about MA expansion, then, have you seen, or how concerned should legislators be about when their state has decided, and for whatever reason, right? You and I can and legislators can disagree about whether they should have expanded MA, but in those states that already have, and I don't begrudge legislators that are in that position that they did take it for whatever their particular reasons are, right? But they have done it, and so now there's an issue that needs to be dealt with. So if the federal government is to cut those funds off in 2 years, let's suppose they do. It's in most cases the Fed's going to dial their dollars back as opposed to cut it off. Well, let's suppose they cut it off for argument's sake. Money is fungible, right? As you and I talked the other day, money is fungible in a state budget. So they take the MA expansion, money that they otherwise would have put into their health services, then gets rerouted to, say, K-12 education. And so this ripple effect happens throughout the state budget as the Fed dials back their dollars, right? So that creates an out-year gap in education funding. And you and I well know, and any legislator that listens to this knows, to cut education is to end your career, right? I mean, I understand it.
Right.
So with that in mind, for those states, if they are concerned about those out-year cuts from the federal government, does it, in your opinion, does it behoove them to plan accordingly and maybe have a rainy day fund built? And I know this is more of a budget question, but I mean, it all stems from this intoxicating rush of federal dollars that we've seen.
Yeah, I mean, I would hope states aren't running a deficit, and I mean, a rainy day fund would be a great idea. I think oftentimes states are searching for ways to increase revenues, and that often looks like excise taxes on tobacco and vaping products, and that's something, we're battling, even at the local level. We have counties and city councils looking for more ways to boost their budget, and they're looking to increase taxes in other ways. And sin taxes are a great way to do it because, it's a bad thing for you. So it's easier to kind of trick the public, persuade them in that way instead of just an instantaneous, property tax increase or something like that. So I would think if there would be a way to move funds within a state budget, or just be aware that look at what other states have dealt with that have accepted Medicaid and or expanded Medicaid. Oregon is one of those states that's dealing with it right now. I think Washington is dealing with it. Look at what their budgets are looking like and read articles about those states and what they're dealing with, because I think to pretend that that's not going to then happen to your state, I think is slightly ignorant, because it's happened before, and it's a ripple effect. It happens with every state that is taking handouts from the federal government. And unfortunately, our federal government isn't the best at managing money. I mean, we're $30 trillion in debt ish with Social Security and other issues. So I think to pretend that the federal government can manage money and then be willing to put your state's healthcare in the hands of the federal government is pretty concerning to me. So I'm sure that they won't cut funds completely, like you said, in 2 years, but I just don't know how long the United States government can sustain itself if it continues the way that it is. I think there will have to be a recorrection somewhere. But so I think it would be great if states could have some type of rainy day fund. I think that would always be beneficial, but I don't know. It's kind of
yeah. So then my next question is kind of tying both telehealth expansion and con law into one question.
Sure.
If I recall correctly, there has been in recent years this expansion of the ambulatory care facilities, right? Basically urgent care type centers, or you'll see orthopedic surgeons set up a shop or what have you. So I'm wondering then, to what extent do those two things intersect and become hand in glove, servicing rural communities? Because it's kind of like a satellite facility. No, you build an ambulatory facility, and then you're actually just that much closer to or more difficult to reach populations, especially in states, like my home state of Wisconsin, that has substantially large rural communities or far-flung rural communities. Just your thoughts on how that interplays, or even to discuss in that same vein, licensing issues.
Yeah, well, I think anytime that you allow the market to work, the people demand what they want. And I think our society is moving in a direction of, a technological age where everyone has a cell phone in their pocket. And that's a really great benefit. And we should utilize that benefit, right? And I think con law is reforming or repealing con law is somewhat similar, allowing the market to determine what it needs. I don't think that the government can determine necessarily how many hospital beds, a community needs. And I think COVID-19 pretty plainly pointed that out, right? We had hospitals that couldn't keep up merely because of con laws. And so we also see with certificate of need laws, healthcare prices on average are higher in states with certificate of need laws. And so allowing the market to make the determination on what it needs is just huge, whether that's with technology or literally developing healthcare facilities to how many beds a healthcare facility has. And con laws, it's a huge range. I mean, we're talking very vaguely here or broadly because certificate of need law is different in every state, and it can, oversee so many different aspects of our healthcare. But at the end of the day, it requires a bureaucratic process where the government is going to determine what is and isn't necessary. And I do think with rural communities, or even a good example was my dad had cancer during the COVID-19 pandemic, and it wasn't great for him to just go to the facility, or it wasn't easy for him. So he was able to call his doctor, and that was utilizing telehealth, just calling your doctor as a part of telehealth. It doesn't have to necessarily be a video call to get information back and forth from patients to doctors. And again, I think the main goal is to always have a patient in a facility. But if that just can't happen, like you mentioned, rural communities need care too. And we see a huge disparity between care between urban and rural communities. And if this is a way to bridge that gap by repealing certificate of need law and telemedicine expansion, which research shows it does, I just don't see why any politician on either side could be opposed to this. Again, unless you have established industry leaders in your pocket funding your next campaign, or taking you out to nice dinners. I'm sure it's hard. But I think, telemedicine and con law do go hand in hand. And I do hope in the future we continue to see progression on both of those policy areas.
I recently read an article, and this is less a question than a comment for legislators to consider, and I know you saw it as well, was an article about the shortage of midwives in Appalachia. And it was actually exacerbated by the pandemic. And I thought it was interesting because I became aware of the issue by a Google alert on certificate of need. So you go down this rabbit hole. How did this happen? Why is there the shortage of midwives? And it turns out that because of, in certain communities, you have these certificate of need laws that make buildings ambulatory facilities or women's healthcare facilities difficult to challenge or cost prohibitive. And there was, in these rural communities or these hard to reach communities like in Appalachia, have high infant mortality rates and high maternal mortality rates, which is of course sad. And we also see the very same issue afflicting urban communities as well. Disadvantaged communities, lower socioeconomic communities, and minority communities in urban areas also suffering from high infant mortality rates and high maternal mortality rates or childbirth rates. So again, my point is just that these few changes literally, seems to me, as not a healthcare expert, but it seems to me there's a direct line from making these reforms and saving lives. And I am, as I know you are, in loath to use hyperbole. I don't want to exaggerate and oversell something. I'm not comfortable with it. So I don't like to use hyperbole. But in this case, I have result A can be cured by or solved by solution B, or vice versa, however you want to say it.
Right.
So that's my soapbox in that one example. So we just talked about top three issues if you could encourage legislators to not to pursue to help reform healthcare in their state. The converse side is, what three issues should legislators be on the lookout for from their colleagues? What three issues, or maybe there's only one, or maybe there's 10 you want to go through, but what issues or policies should legislators be very skeptical about pursuing? And if they have colleagues, should they fight tooth and nail because it will drive cost or decrease access or hurt the taxpayer, in your opinion?
Well, on the reverse side, I would say Medicaid expansion again. So watch out for those that are supporting Medicaid expansion. I really do think it's a wolf in sheep's clothing. Like I discussed before, I really do think that at the end of the day, you might be out of office, but your budget is still your state's budget, and the taxpayer is still going to be on the hook for any of that funding. So I would just continue to keep an eye on Medicaid expansion. I have a feeling it's going to be pushed until we're all on a universal healthcare plan. And I think that's the goal. We can all agree on that. Something else we actually saw this in Colorado. So we've seen price controls at the federal level with the International Pricing Index, and then they changed the name several times. But at the end of the day, it's still the government fixing prices on pharmaceutical drugs. We saw this in Colorado. The governor of Colorado is actually, one of his main goals is to create a state board that would determine prices in the state for pharmaceutical drugs. And rare disease activists especially are on high alert because they're very concerned that pharmaceutical companies are not going to invest in research and development if, the profit share, the profit margin, is determined by the state, and they're not going to make enough on their drug. And for people that are, living with a debilitating disease in some capacity, this is very, very concerning. So I would just look out for any price control measures. Anytime the government is going to set prices to anything, but especially our healthcare, oftentimes that impacts research and development. And if anyone out there is a small business owner, you understand margins, and that really is something the market has to determine. That's not something the government can. I would say anything related to COVID-19. We saw executive power overreach. We saw, we saw mask mandates. We saw, what else do we see? Potentially, requiring vaccine passports. We saw, just every regulation that any, power hungry politician could pull out of their, pocket that limited your freedom and your ability to make decisions for your family and who you see on Thanksgiving. I think fighting freedom and civil liberties, fighting for freedom and civil liberties in that capacity is so necessary, and to be vocal about it, because as constituents, we support you all in fighting for those issues. I guess also the excise taxes. I think that a lot of states, I can think of a few, are trying to scrounge up money for revenues. And I think that excise taxes, we're seeing that all over the place, just increasing, expanding. So just fighting the sin taxes, and then also making your constituents aware. I don't think that as many people are aware, but how much it impacts the poor. So, the lower 50% are actually paying 10 times more, than the wealthier population compared to their overall income. So it's very costly for low income earners. And I think using that argument would be a good way to defend a position not to increase excise taxes or sin taxes. And that's all I have off the top of my head, but I'm sure there's more.
No, that was good. And, so dovetailing on the Colorado point over the pharmacy control board or whatever
Yeah, that's
whatever
basically what it is.
whatever government name they came up with. So dovetailing on that, so a hot topic that we've seen, and I hate to put you on the spot, that we've
No,
seen
you don't.
develop in the States. And I've had conversations about this, and I know I haven't particularly settled on it, but I do know the upsides and downsides of these are pharmacy benefit managers.
Okay, yeah.
To what extent have you seen those become an issue? We'll start there.
I'm not an expert in this subject, but I know Anne Marie, who works on our healthcare news, has dived very deep into this. So I know we do have some resources on our website, but I just don't know enough about like PBMs and how it intersects with healthcare within the states. I just don't feel confident enough to speak on it. But I know we do have some really good articles on it, and some of our fellows have written good pieces on it.
Yeah, and my take on PBMs in my cursory review is that I think the point of them from a government perspective. Now, I mean, pharmacy benefit managers have been involved in the healthcare process for several years. You have CVS Health is a big provider of these services as well. So these PBMs then get large government contracts to kind of procure savings. Really, they're basically these entities that negotiate drug prices on behalf of government X, whatever said level of government is. And the issue it has come up that these PBMs are not they negotiate these prices by purchasing in bulk, and then those prices or those savings then are being kept by the PBMs and not being passed back to taxpayers. And so I've seen the legislation come along that those savings should be given back to taxpayers in the form of lower MA rates or however a budget process may determine that. So that's the issue. But to the representative that asked, please check our website. And if you have questions, Christina or I are happy to answer whatever questions you have after the program. Christina's email is Herrin@heartland.org, and mine is Sholty@heartland.org, and we're happy to answer any questions. Another question that came up for some folks that might be newer legislators: how would you describe what direct primary care is? If I'm John Q. Public, or I'm a brand new legislator, and I'm just trying to find my way in this legislative process, what is direct primary care?
Sure. So direct primary care is an alternative to our third-party payer insurance program. So right now, I have health insurance through my employer, and I go to the doctor when I'm sick, and the doctor has to submit loads of paperwork, and there's tons of administrative fees and costs associated with it to then submit back to my health insurance provider. So there's this, anytime you have insurance, there's a lot of pieces, whether it's car, house, health, but direct primary care would really get rid of that middleman, and you would be paying a set fee to your doctor, monthly or annually, and you would then have access to your provider, for all the same, primary care needs you would get through your current healthcare insurance. So a yearly checkup or whatever your primary care physician sees you for now. And that's often a lot cheaper, and it often allows the direct primary care provider to see more patients because they're not spending all of the time or hiring other people, to handle all the administrative, obstacles that there are currently established with our current insurance system. And then also with direct primary care, the way the system would work is you would have your agreement with your healthcare provider, but you would also have a catastrophic policy in case you obviously get cancer or have some type of accident that no one ever plans for, but you would really need more specialized care that would be different, and that would still go through an insurance. But the direct primary care model is a really good one. And again, South Dakota just codified law. So a lot of the states is actually different again than being reactionary to policy. This is like one of the times us as free market people get a support policy, and it would codify into law direct primary care as being different from health insurance, so they can avoid a lot of the regulations, again, which raises costs that health insurance programs and facilitators have to go through now. So a direct primary care is a really good option, and it really gets us off this current this current model that we're in that really isn't working. And it's also not working because we have half of the people on government and care, and then some people on the individual market, and then we have some people through their employer-based health insurance. But really moving off of the health insurance model is something I have been a strong proponent of my entire political or policy career, because you obviously have health and car insurance, and when our furnace breaks or we have our window needs to be fixed or something like that, we don't submit it to our house insurance. Or our car needs an oil change, we don't submit that to car insurance. We just pay for those things out of pocket, and we really save our car and home insurance for these catastrophic things. And here in Iowa, we had a huge windstorm, a derecho, and it tore down houses. That'd be a really good reason to use your your house insurance, submit a claim. But now when you have a crack in a window or something of that nature, so allowing health insurance to operate in the same way, I think, is the best way to think about direct primary care. It really is to facilitate primary care for what it is, and then allow you to just pay a fee, and it's a small fee. It's less than your monthly health insurance is typically, on average it is, and then you have access to your primary care physician in your hometown or wherever they are. And again, for more serious needs or things like that, you would have a catastrophic plan. So just moving in that direction, I think, is a really cool concept, and looking for an alternative, because obviously healthcare costs are increasing for everyone in the country. Almost all states, I think, are seeing increased healthcare costs, and finding ways to drive down those costs. And really a big cost I think people don't think about is that third party, that middleman, that those administrative fees and a lot of the paperwork that is now required that really isn't necessary when you use a direct primary care model. So I think it's a good alternative. I think it's something to consider. Obviously, speaking with physicians in your states, I think there are a lot of physicians. There's a national organization for direct primary care physicians that are supportive of this type of reform, because it's better for them. And so if it's better for the doctors and the patients want it as well, I think giving that option. And I think that's what here at the Heartland Institute, we're about options. We're not forcing people to use telemedicine. We're not forcing people to be on direct primary care plans. But I think if it's a better option for you and your family, you should have that choice within your state. And so I think that's something that y'all should look into. And I'd love to talk more about direct primary care. I can point you to physicians or other experts who have been doing this, for longer than I've been alive. So if you have other questions, I'd be happy to kind of point you in the direction or get you any research that you need on direct primary care, because I think this is really going to be the future of healthcare. And again, in hand with telehealth and things of that nature, I think we can move in the right direction. And we have people and politicians pulling on us and on the heartstrings of America, trying to get us onto this socialized, healthcare system that's universal healthcare, and the federal government's going to run it all, and it's not going to cost us anything. And we obviously know that not to be true. So I think this is a really good alternative, and to use, against a lot of those naysayers or those people that are so simplistic, right? It's just, we need universal healthcare and it's going to be free, and we need universal housing and everyone needs free, food. And it's very simplistic, but it really is more complex than that. So I think direct primary care kind of fills that gap as an alternative to our current status quo healthcare options. So.
All right, very good. Well, it's getting on in the hour. So why don't we, if I don't see any other questions, I'll wrap this up. Christina, great job. Thank you so much. I appreciate it. I know this will be a helpful resource to many legislators. And if anybody has any questions, please email me, csholty@heartland.org, or Christina, Herrin@heartland.org, or you can visit our website, heartland.org. And if you have any questions, please let us know, pass those along. I want to thank everybody, Christina, Jim, and the legislators who joined us today. Thank you for participating in our summer webinar series. Next week, we're doing another one of these right around the same time on energy and climate issues facing the states. So if that's an issue you're interested in, please look out for the email to register. If not, again, thank you, everybody. And I can't thank you enough for participating. Have a good weekend, and we'll talk to you all soon. Thank you very much.